My name is Rebecca Logsden. I am a psychologist and part of the faculty of the Alzheimer's Disease Research Center. And I'm happy to tell you that this is our 23rd annual Alzheimer's Disease Public Forum that's been conducted by our Alzheimer's Disease Research. And we welcome all of you, some very familiar faces and some new faces who are here tonight. We do want to acknowledge our supporters of the program tonight, particularly the University of Washington Alzheimer's Disease Research Center, which is funded by the National Institute on Aging. The Friends of Alzheimer's Research, which is a local group that has been very supportive of the educational program of the Alzheimer's Disease Research Center, and also in providing seed money for innovative new grant proposals. Are any of our Friends of Alzheimer's here tonight? Thank you very much for many years of support. We also have a few other sponsors that we have listed here, and I want to especially thank Kat Olcott and Elizabeth Sharp, who are on our staff, who really did the lion's share of the work organizing our program tonight. The University of Washington Alzheimer's Disease Research Center, or ADRC, was funded by the National Institute on Aging. It was one of the first centers in the country to be funded, and we have been continuously funded since 1985. The purpose of our particular research center is to facilitate cutting-edge research on causes and treatment of Alzheimer's disease and other dementias, to enhance the clinical care of patients with Alzheimer's disease and their caregivers, and then to provide community and professional education about Alzheimer's disease and dementia and caregiving. You can see on this slide that the Alzheimer's Disease Research Center is kind of like an octopus. There are many, many researchers involved with the center doing individual projects and working on the center as a whole. And some of them are probably there in their offices and labs tonight working away. But the most important people to our Alzheimer's Disease Research Center are the people who have volunteered to participate in our research studies. And I know also that some of you are here tonight, but I won't ask you to raise your hands. But I just want to express our deepest admiration and gratitude for all that you and your families have done to help us learn more about this disease. Tonight we're going to hear about some of the new exciting things that are going on at our ADRC, but we're only going to hear a sampling of them. And on this slide I've listed some of the other things that we're not necessarily going to hear about tonight in detail, but that we do have people working on as we speak. And I want to encourage you, when you leave here, if you didn't already, pick up some of our brochures and our newsletter. It's called Dimensions, to pick that up on your way out and take it with you, because that's the best way we have of keeping you informed of new things and what's going on at the center. And we also, of course, are always looking for new people who are willing to volunteer to participate in our research. And we are looking for all different kinds of people. You don't have to necessarily have Alzheimer's disease. You don't have to have memory loss at all to participate in the center in some of our studies. We are interested in talking to you if you are interested in volunteering. So do pick up the brochure and give us a call. This just gives you an idea of some of the ways to get involved with the research center. We also have our Alzheimer's Disease Research Center webpage, and it's just uwvideo.org. That will take you there. If you pick up the newsletter outside, you can join our mailing list, and it will be mailed to you each month. And if you think that you're interested in research, but you're not quite sure, you're not committing yourself at the time that you call. You're just getting information. And so please feel free to give us a call and hear about what's going on. We're going to move into the next part of our program. We have two speakers tonight, and we're fortunate to have two internationally known experts about Alzheimer's disease right here at our Alzheimer's Disease Research Center. Both of them are long-term faculty members, and I've known and worked with both of them since I came here as a postdoctoral fellow in 1986. I have the utmost respect and admiration for both of them, their work, and as both clinicians and researchers. We are very fortunate to have them here. And I want to start off by introducing Murray Raskind is going to be our first speaker, and he's going to be talking about medication treatment of agitation. And then our second speaker is Dr. Linda Teri, who is going to be talking about psychosocial approaches to enhancing care for people with dementia. I'm going to introduce Dr. Raskind, and then I'm going to, when Dr. Teri gets up to talk, I'm going to introduce her as well. Dr. Raskind is professor and vice chairman of psychiatry and behavioral sciences in the UW School of Medicine. He is director of our Alzheimer's Disease Research Center. He directs the mental health service at the VA Puget Sound Healthcare System and is director of the VA Northwest Mental Illness Research Education and Clinical Center. Dr. Raskind's research efforts are focused on studies in Alzheimer's disease, aging, depression, and non-cognitive behavioral problems in dementia. His expertise in geriatrics and gerontology has been acknowledged by his appointment to numerous scientific editorial boards, including the Medical and Scientific Advisory Committee of the National Alzheimer's Association, the Board of Directors of the American Geriatric Society, the Neuroscience, Behavior, and Sociology of Aging Review Committee of the National Institute on Aging, and the Scientific Advisory Committee of the American Federation of Aging Research. I am very pleased to ask Dr. Raskind to come up.
Thanks, Rebecca, for the kind introduction, and thank you all for coming, and thanks especially to the Friends of Alzheimer's Research and all the persons who participated in our studies. You know, it's hard to volunteer and say, I'll be a guinea pig and participate in research. It sounds like a great idea until you go to pick up the phone, and then it's a little tougher. But it turns out that people who are in research do better than people who are not in research, regardless of the study, regardless of what you get or don't get. So it's actually a beneficial experience, and it's really the only way we're going to move forward to conquer this dreadful epidemic. And the introduction, I think you were talking about me. I'm a geriatric psychiatrist, and now that I'm 65, I'm officially a geriatric psychiatrist, at least for Medicare purposes. And I actually tried to sign up for Medicare, you know, go through the call up and try to hit this number and that, and it turns out people were right when they said it's not so easy to get through these systems. But I'm going to try to master it. But I decided to defer until after I gave this lecture because I wanted to concentrate all my intellectual abilities on presenting a few points. All right. So let's see. My cell phones are off. My BlackBerry is off. We're now ready to take off. Here we go. Okay. Disruptive agitation. I mean, what is disruptive agitation? We're talking about a group of behaviors that often cluster together and are more common in persons who have Alzheimer's disease and related disorders that destroy brain nerve cells and therefore impair memory and intellectual function. And these are not mysterious type of behaviors, but they cause tremendous problems. Irritability, anger outbursts and aggressive behavior, sleep disruption, pressured pacing and restlessness, and uncooperativeness with necessary care. And I want to emphasize the necessary care, because all of us sometimes are uncooperative when we think we want to do something and someone else thinks we should do something else, and that's fine. But when it comes to hygiene and taking care of basic personal and medical needs, this uncooperativeness, especially when accompanied by irritability and anger outbursts and pressured motor activity, can be very difficult and harmful to many persons, not just the patient. Why is it important to treat? Well, sometimes we can't tell what a person with advanced Alzheimer's disease is really trying to communicate. And I want to emphasize that these agitated disruptive behaviors are increasingly common as Alzheimer's disease progresses to its middle and later stages. But we can infer that the patient is distressed. And for those who can communicate with us, it's clear that they are distressed, even though we're not always sure what they're distressed about. Certainly, the caregivers are distressed. And disruptive agitation is a major part of caregiver burden. Ability to provide care is compromised. Sometimes there's even a threat to the safety of others, especially in the long-term care environment when a person with Alzheimer's disease who is suffering from disruptive agitation is surrounded by other frail, older persons who can't get out of the way. And it's also been repeatedly demonstrated that persons who have disruptive agitation, severe enough to require medical or behavioral management, have a steeper rate of decline than those who don't. Now, this may mean that these people would have a steeper rate of decline whether they were treated or not, but it's also possible that the processes that underlie disruptive agitation are actually harmful to the survival of brain tissue. And that's another potential reason to treat. Now, the ideal approach to treating any medical condition is to figure out what's causing the problem at some biological basis, and then to correct it. For example, to take a totally different class of disease, diabetes. We know diabetes is caused by, at least in a subtype of diabetes, a deficiency of the hormone insulin. So we decide to treat diabetes by giving insulin, and therefore we normalize blood sugar and at least take care of prominent symptoms of diabetes. We'd like to do the same thing with disruptive agitation and Alzheimer's disease. We'd like to discover the brain biology basis of disruptive agitation in Alzheimer's disease, and then use medications that would counteract that brain abnormality which is causing the disruptive agitation. Or, I think more accurately, lowering the threshold for a person to get agitated in a situation in which a person who didn't have that abnormality would remain calm and not be upset or upsetting. Now, the currently used medication approaches are derivative. What do I mean by derivative? Well, if we don't know the cause of something, but in other areas of psychiatry, we have drugs that work on other diseases in which persons become upset and agitated, the natural tendency for physicians is to say, well, gee, maybe it'll work for disruptive agitation in Alzheimer's disease. Some of those other diseases where agitation is prominent are schizophrenia, where sleep disruption is common, insomnia, anxiety disorders, other problems. And that's what's been done in geriatric psychiatry in the care of disruptive agitation in Alzheimer's disease. And I must share with you that this approach has not been tremendously successful. We've made some modest gains for some people, but it's not been tremendously successful. And just to, again, emphasize that point, because we don't know the brain biology underlying agitation in dementia. Drugs effective for other psychiatric disorders have been borrowed to treat agitation in dementia. Let me throw out one definition for you, because I changed some of the wording. I started talking about Alzheimer's disease and then I switched to dementia. So let me define what I mean by dementia. Dementia is not a disease It's a syndrome, a group of things that happen and symptoms, things that a person complains about, that group together. And in dementia, the most prominent symptom is impairment of memory. And this impairment of memory is caused by some brain disease that damages or destroys brain cells called neurons that are the basis for our ability to remember. And lots of diseases can do this. And it doesn't have to be in an old person. So persons who have been professional boxers get dementia from repeated trauma to the head that damages brain neurons. But in later life, the most common cause of the dementia syndrome is a disease called Alzheimer's disease. So hopefully, when I go back and forth, because in some of the studies they use the term dementia because they include persons with Alzheimer's disease, dementia due to blood flow insufficiency, dementia due to Lewy bodies diffusely throughout the brain, I'll use dementia. In other times, I'll use Alzheimer's disease. And for the purposes of disruptive agitation, this distinction is not particularly important because the approaches to management, whether they be the behavioral approaches that Dr. Teri will talk about later, or even the medication approaches, are quite similar. The most common group of medications that have been borrowed from general psychiatry to treat disruptive agitation in Alzheimer's disease and related dementia disorders are the antipsychotic drugs or the anti-schizophrenia drugs. And some of these will be familiar to some of you. The older one is haloperidol or Haldol. Is that familiar to anybody? Heard of this medication? Risperidone, olanzapine, these are all, and others, all drugs that have been used to treat schizophrenia and other psychotic disorders in younger persons who don't have dementia, who don't have Alzheimer's disease, have been borrowed. And I must say that they are better than nothing. They're more effective than placebo for disruptive agitation in studies that have been done. But they're not tremendously more helpful. There are frequently persons who don't respond. Adverse effects are quite common. So for the older drugs like haloperidol, if you take a little bit too much, you become very stiff and you seem to appear similar to a person who has Parkinson's disease. Not a very good outcome. Also, these drugs are sedating. They put one to sleep if you take too much. Now that at times can be useful for a short period of time, but on a chronic basis, that's dangerous. We were taught in medical school back in the 1960s that if you take an 85-year-old person and sedate them for 10 weeks, some of them are going to get very sick and some of them are going to die. So the increased risk of stroke and death associated with the antipsychotic drugs, we now know is due to the sedating properties of these drugs. And that puts us in a real bind, because when I get a call from the nursing home personnel that someone is agitated and scary to the staff and scary to the patient, they want me to sedate the person. They want things to quiet down. So my job is to educate, not sedate long term, but also to look for other medication approaches which don't cause sedation, which don't increase the risk of stroke and death, that work equally well or maybe even better. Just give you a few examples of what I mean by the antipsychotic drugs, working a little but not terrifically. Probably the most commonly prescribed one is a drug called risperidone, and it was introduced for schizophrenia, and there have been studies in persons with dementia and disruptive agitation, and it is more effective than placebo, but as you increase the dose, you get increasing somnolence or sedation and increased Parkinson-like stiffness and rigidity. And it's also associated with developing swelling of the lower extremities. And it doesn't work much better than placebo. This is a comparison. Don't worry too much about the numbers. But on the left-hand side, we have risperidone, and the number 3.2 in the rating scale translates to, at the end of the study, minimally improved to unchanged. And on placebo, persons were unchanged to minimally worse. Better on the active medication, but not terrific. Another drug, olanzapine or Zyprexa, commonly, probably the second most or the third most commonly used antipsychotic drug. Again, somewhat better than placebo, but only at a specific dose. 5 milligrams was better than placebo. 10 milligrams was just a little bit better than placebo. And 15 milligrams was actually worse than placebo. And a low dose, 2.5 milligrams, didn't work any differently from placebo. Furthermore, not a big difference in improvement. We're going to look at a different scale. This is the neuropsychiatric inventory, which measures a group of behavioral problems. And again, in the middle box where we see olanzapine in the greenish color, people improved about 19 points on this scale. But on placebo, not a bad drug, they improved 10 points. A little advantage for olanzapine. We have to take the questions, I was told, have to come after Dr. Teri's talk, but don't forget it. This is not a test. Good, all right. I won't forget to ask either. All right, so what have we found about the basic biologic changes in Alzheimer's disease that may contribute to disruptive agitation? Well, we took a somewhat simple-minded approach. Well, gee, agitation, you're overstimulated. Adrenaline, that's the hormone that when you're in a dangerous situation or a stressful situation is secreted that makes us feel anxious, makes us feel alert at low doses. That's a good thing. But too much makes us feel anxious and fearful and, frankly, agitated and irritable. And those of you who have lived with a different population called teenagers, it's a different series when we talk about them, know what we're talking about. We're not just talking about later life. And we ask the question, does excessive noradrenergic activity contribute to agitation in Alzheimer's disease? I used and introduced another word, noradrenergic. The brain's adrenaline is called norepinephrine. And scientifically, the system is called the noradrenergic or the noradrenaline system. So one of the things we do in science and medicine is try to use as many confusing words as possible so we can bill. That's what. Does that have to be on TV? I don't know. Because I may get kicked out of the local society for that. Me. All right. Luckily, I'm 65, you know. I can just go on almost on my Medicare. So what have we found out? Because no one thought this was such a hot idea, because when you examine the brain of someone who has passed away after suffering from Alzheimer's disease, the nerve cells that make norepinephrine, these adrenaline-like producing nerve cells, are actually reduced in number. There are fewer of them. So at first, you know, when we were interested in the system, we said, well, maybe actually the norepinephrine system is more involved in memory and it's low, and we can demonstrate that norepinephrine is low in the person with Alzheimer's before life. We can give them more norepinephrine or something like norepinephrine, and people will be able to remember things. We weren't really thinking at the time, frankly, about agitation. But it turns out when we did studies in which we sampled cerebrospinal fluid, the fluid that surrounds the brain, doing a pain-free atraumatic lumbar puncture performed mostly these days by my colleague, Dr. Elaine Peskin. We found that even though there are fewer neurons in Alzheimer's disease making norepinephrine, the brain's adrenaline, the amount of norepinephrine surrounding the brain and in the brain was normal. and in the more advanced stages was actually somewhat elevated. We also found that when we gave a medication that increases the brain's release of norepinephrine, increases the adrenaline-like activity, and we gave it to persons with Alzheimer's disease who were outpatients who were doing pretty well at home, and to normal persons at the same age. The normal person at the same age felt like they had had 2 cups of coffee. They just felt more alert, a little more talkative, seemed to enjoy the study a little bit more. Right. They didn't realize it was decaf adrenaline. Whereas the Alzheimer's subjects in the study became extremely agitated. They each put out, by our lumbar puncture, the same amount of norepinephrine. But the same amount of norepinephrine causes the Alzheimer's person to become agitated and upset, whereas it causes the normal person of the same age, these persons were mean age in their late 70s, just to be more alert, the normal response. Finally, we found that receptors for norepinephrine in the brain, all chemicals have a receptor. The chemical floats along, hits the receptor, and the receptor says, okay, time to wake up. Or if it's another receptor for a sleepy chemical, okay, it's time to go to sleep. And we found that the alpha-1 epinephrine receptor, which is a major receptor in the brain for norepinephrine, was elevated in Alzheimer's patients. And I'll show you some of the evidence for those of you who are interested in what I call the neuromythology, the neurobiology of this. All right, here are our cerebrospinal fluid studies, and these include persons who are young, 54 young persons, many of whom are medical students. How normal that makes them, I'm not totally sure. 42 older persons, mean age in their later 70s. 49 persons in the pink bar with mild to moderate Alzheimer's disease, and 25 persons with advanced Alzheimer's disease who were in long-term care when the study was done. And we had predicted that norepinephrine would be lower in the normal old persons and very low in the Alzheimer's disease, especially in the more advanced people. And lo and behold, we found it went in the opposite direction. So you can see how well we thought out the rationale for this study. And what we've learned over time is that sometimes what you stumble upon is more important than what you rationally predicted should have happened based on the knowledge one had at the time. But be that as it may, so gee, even though we've lost a lot of nerve cells that make norepinephrine in the brain in Alzheimer's disease, the amount of norepinephrine is normal or even going up in the advanced stages, and these advanced stages are exactly when people get disruptive agitation. Now it turns out there have been studies in animals, all of whom, of course, have signed an informed consent to participate in research, that if part of their locus ceruleus, another term, the locus ceruleus is a group of neurons in the brain that make norepinephrine. And it's the only site where norepinephrine is made. And if you damage part of the locus ceruleus, or damage 1 out of every 2, or destroy 1 out of every 2 locus ceruleus norepinephrine neurons, the neighbors react by increasing the amount of norepinephrine that they make. So each one of them doubles the amount of norepinephrine it makes. So even though you only have half the amount of neurons, you have the same amount of norepinephrine coming out. They've compensated for the problem. So we asked whether this phenomenon was occurring in Alzheimer's disease. And one of the things that we do that's very important in our Alzheimer's Disease Research Center is enroll people early in the course of their illness and follow them for a decade or more. And when they die, they have decided to contribute their brain tissue for scientific study. So we had brain tissue available, and we were able to look at the locus ceruleus in persons with Alzheimer's disease and persons who died of something else but were normal cognitively at the time, our control or comparison group. And we used tyrosine hydroxylase messenger RNA, about which you will not be tested after this lecture. But it's a measure of the ability of each neuron in the locus coeruleus to make norepinephrine, the brain's adrenaline. And what did we find? Okay. Don't worry about this slide. I just put this in case there are some scientists who will be reviewing my grant next time, just to show you. But this is these are the two slides I really wanted to focus on. This is the sky over Seattle in early January. The only joke I put in the talk. And, so this is the normal locus coeruleus. And each one of these very bright areas is a neuron. And each dot of light is a molecule of the chemical that makes norepinephrine. So you see, if you look at this, you know, there are lots of galaxies here. And I'm now going to show you the sky over Seattle in early January. Well, anyway, the locus coeruleus of a person who died after about 10 years of Alzheimer's disease and had disruptive agitation for several years. Many fewer galaxies, but each one brighter. So fewer neurons, but each neuron is revved up. And they're making a lot of norepinephrine. So each time, and you know, what does the locus coeruleus do? Well, the locus coeruleus says, well, there's something new in the environment. I have to focus my attention on it and become alert. And in the Alzheimer's patient, that's happening almost all the time because they can't remember what was going on several minutes ago, especially in the more advanced stages of the disease. So they're always having this firing response, and they're putting out a lot of this alerting neurochemical. Okay. All right. And finally, and I'm not going to show you the slides, but just look at the bottom of the slide. In the same brain tissue, but out in the areas to which the locus coeruleus neurons travel to tell the rest of the brain, time to be alert, something's happening, pay attention. You have to respond to the environment. We found increased amount of these alpha-1 adrenergic receptors, or the alpha-1 receptor for the brain's epinephrine called norepinephrine. So we have a lot of norepinephrine coming out and a lot more receptors. So you get more action in the Alzheimer's brain to stimulation from the environment. So, you know, we said, well, gee, you know, it looks like it's a little upregulated. Let's see, did we try to increase it and make people more agitated? No, let's try to reduce it and see if that will make persons less agitated. And it turns out that there are drugs that were introduced in the 1970s to treat high blood pressure, which reduce the amount of response to norepinephrine. Because norepinephrine in the periphery, the adrenaline, also increases blood pressure. And some of these drugs actually are able to get into the brain, but not many of them. Just the old-time drugs are able to get into the brain. We're assuming that agitation in Alzheimer's involves the brain. Because the newer drugs were designed not to get into the brain, because that's less likely to give you behavioral side effects. So we said, let's look at the old drugs. And it turns out that a drug called Prazosin, which was introduced in 1973 as mini-press to treat high blood pressure, blocks the alpha-1 receptor and crosses from blood into brain pretty easily. And that's the only one of its class that does it. So we asked whether it would be helpful in Alzheimer's disease. Now, this drug has a problem. It's cheap. You know, new drugs come out, they're all very expensive because they're under patent by the pharmaceutical industry, and that's why they invest $100 million in developing the drug. But we're trying to see if a cheap old generic drug that's been safe in millions of older persons with high blood pressure and also benign prostatic hypertrophy, for those older men in the audience, you'll understand what I mean. But we, luckily we had our Alzheimer's Disease Research Center. We didn't need the pharmaceutical industry. We were able to do these studies anyway. And we tried it in a couple of people who were agitated despite being treated with the antipsychotic drugs and sedative hypnotic drugs and antidepressant drugs and all the other drugs that people are treated with often ineffectively. And gee, it seemed to be really helpful. And we also found that it was helpful in persons with post-traumatic stress disorder, which is another interest of ours over at the Department of Veterans Affairs, where our Alzheimer's Center geographically is located. And it has a very low side effect profile. In contrast to the antipsychotics, it doesn't put you to sleep. It doesn't cause Parkinsonism. And for those whose blood pressure is a little high, it actually reduces your blood pressure a little bit. Now, you have to be careful when you first start the drug not to reduce blood pressure too much, like any other blood pressure lowering medication. But if you're careful, it's a pretty benign medication. So the first thing we did was do it open label, and at the Klein-Gallant home primarily, where we've been providing geriatric psychiatric consultation pro bono since 1974, when Karl Eisdorfer first showed up and needed someone who could actually do it. This is just for private consultation among the faculty here. We gave Prazosin for 8 weeks. Person who had agitation was well tolerated, and they did well. Now, when you don't use a placebo, everything looks good when you do something without a placebo. It's one of the laws of modern medicine. So we did a placebo-controlled study, and this time we included 21 persons with Alzheimer's disease. Some were at home, some in long-term care facilities, and we gave them Prazosin to random order. We didn't know who was getting what, and the persons didn't know who was getting what, and the caregivers didn't know who was getting what. The only people actually who remembered what they were getting were the patients with Alzheimer's disease. I can't understand that. And we treated them for 8 weeks, and we used the average dose was between 2 and 3 milligrams in the daytime and another 2 or 3 milligrams at nighttime. And don't worry about these primary outcome measures. They're measures of behavioral problems. And lo and behold, and here reduction in symptoms is a good thing. So in the pink, we have Prazosin. And in the chartreuse, I think, my daughter's a fashion designer, I gotta get this right. We have placebo. And sure enough, as we predicted, and many times what we predict doesn't come out, but this time it did, the brief psychiatric rating scale, or BPRS symptoms for agitation and excitement and hostility decreased substantially and significantly on the active medication. And when we looked at the neuropsychiatric inventory, we got a reduction of about 20 points compared to no reduction in placebo. So that was gratifying to us. And it turns out when you look at it on a week-by-week basis, it starts working pretty quickly. And as time goes along, placebo works also pretty quickly. But if you wait for 4 weeks, the effect of placebo generally poops out. Not always. I take many placebos at the present time, and I find them very satisfactory. But in most studies, the placebo effect over time will generally poop out. But the medication effect was sustained for at least 8 weeks. And when we looked at global impression of how people were doing, the persons on Prazosin were between minimally and moderately improved, whereas the people on placebo were between no change and minimally worse. And given that these are persons with advanced dementia, that's a pretty impressive outcome compared to other studies. So, we need to do more studies. And no pharmaceutical company is going to help us, because another title of this talk could be "Make Agitation Go Away for a Dime a Day." So, Lucy Wang, our geriatric psychiatry fellow, who's superb, and the rest of our team, is leading up this study. And we We, as usual, need persons to volunteer. And to volunteer for this study, you have to have some agitation, which really means you have to have a caregiver who's getting pretty tired of this situation and wants us to help. And we don't stop any other medications. We just take you as you are. Don't change anything. We just want you to be on Prazosin or placebo for 8 weeks, and then everybody gets the real stuff. So if you're interested in hearing more, call Lucy or pick up one of our brochures. And this is the number at the VA. That's your pager. That's your email number. Or leave a message on our research line. And I want everybody to be writing this down. This is very important. Again, the final note, and then I'll stop because I'm already substantially over my time. Being in research, whether you're on the active medication or on placebo, means you're going to do better than if you weren't in a research study at all. Then you have to wait until after Dr. Teri's talk, and then we're going to do the questions. So, Rebecca? Yeah. So hold on to that. Hold on to that question until after Dr. Teri.
Okay, now I would like to introduce to you our next speaker, Dr. Linda Teri, who is professor and vice chair for research of psychosocial and community health in the UW School of Nursing, and is adjunct professor of psychiatry and behavioral sciences in the School of Medicine. Dr. Teri has directed the Alzheimer's Disease Research Center's Education and Information Transfer course since its inception in 1986. And she is a distinguished clinical psychologist and researcher in geriatrics and gerontology, particularly in the areas of dementia, depression, and non-pharmacologic treatments of behavioral disturbances in dementia. She has served on review boards and task forces on gerontology and geriatric mental health for the American Psychological Association, the American Medical Association, and the National Institutes on Health, and is currently on the National Alzheimer's Association's Medical and Scientific Advisory Council. Dr. Teri is a fellow of the American Psychological Association and the Gerontological Society of America, and last year she received the Gerontological Society of America's prestigious Lawton Award for significant contributions in applied gerontology. Dr. Teri.
My mission today is to talk to you about the other side of treating and helping caregivers and persons with Alzheimer's, and that's non-pharmacological treatments. And basically what our mission is to look and see if we can understand and help caregivers deal with the day-to-day problems, the behavioral problems, the agitation, the wandering, the depression, the repetitive questions, the things that make caregiving so difficult and yet so important to improve the quality of life for the people we care about. So I'm not going to talk to you about medications. I'm not going to talk to you about biology. I'm going to talk to you about people. We have a series of interventions that we have done to date, and this little slide with our umbrella, because of course we're in Seattle, we need an umbrella. We began by looking at depression in about 1997. We looked to see whether we could help caregivers who were providing care for persons with dementia who were also depressed. Could we help them with strategies that would improve the depression? We then went on to look to see whether we might be able to help people who were dealing with people who had agitation. Because as you heard from Dr. Raskind, agitation is often one of the critical problems that occur and cause people to think about institutionalization. What we try to do is look at the different kinds of behavioral problems and apply a systematic intervention to them. So we moved to look at physical activity, sleep problems, and most recently, early stage memory loss, mild cognitive impairment, and what we're calling STAR and STAR-C, which I will talk about a little bit later. This is a very old slide, but I keep it in here because I want to remind us this is historically what our population was like. Fewer older people, more younger people. This is what our population is like now. By 2010, which is not so far away anymore, For everyone 65 to 75, there will be somebody 75 plus. Most of us will be caring for our parents during our own retirement years. Caregiving is becoming our national pastime. And it's why we all have to be attentive to what makes it easier for us and what helps the older adult enjoy their later years. This is a little cartoon, Ziggy. Many of you see him in the paper, and it's really true. Circumstances beyond your control. That's what caregiving feels like. So one of the main things we try to do is create some control, to give caregivers strategies and skills and an attitude and methods that provide some structure to what can often seem like a very hopeless problem. Alzheimer's disease is an equal opportunity disease. It affects women, men, rich, poor, and multiple ethnic groups. I'm just going to flip past these quickly because I'm aware of our time constraints. But I want to make sure we all know what Alzheimer's disease is. It's a progressive degenerative brain disease. It starts slow, and it progresses at various rates for various people. Most often, those of us who are caring for somebody with Alzheimer's disease have the experience, well, it kind of started slow, and mom or dad were having problems, but now they're having a lot of problems. And that's the scary part of the disease. Memory, language, judgment, social, personal behavior, personality. The brain is who we are. And as the brain becomes ill, who we are becomes more problematic. And so while the person with Alzheimer's disease certainly has still the integrity of who they are, they're experiencing problems that if they knew they were experiencing would probably cause them great deals of embarrassment. The most significant risk factor for Alzheimer's disease is age. The numbers change depending on who you read, but there's about a 5% prevalence. That means 5% of the population over the age of 65 has Alzheimer's. And depending on what statistics you read, 20 to 50% over the age of 80. Alzheimer's disease is the most common form of dementia. You heard from Dr. Raskind, dementia is the syndrome, and Alzheimer's disease is the most common form. So, what is a clinical psychologist doing looking at Alzheimer's disease since it's a medical condition? Alzheimer's disease, as I said, affects every part of brain function. It's related to other medical problems. Just because you get demented doesn't mean you're not getting ill for other reasons. Behavioral problems you've heard about. Social interactional problems, those social graces that we learn as we get, when we're young, and we hopefully get better at as we get older, we might start to lose them if we become demented. And functional problems, day-to-day care becomes increasingly difficult. This little man has been with me for a long time. A colleague of mine, Dr. Burton Reifler's wife, actually drew him for me. He has a broken leg. And as a clinician, I want him to be able to walk. So I will look to my medical colleagues to fix his broken leg and help him walk. But in the meantime, he's carrying around this ball and chain of disability. And if I can chip away at the disability, if as a caregiver, as a family member, I can chip away at the disability, he will walk better. And that's what we're talking about today. Behavioral problems are very common. They occur day in and day out. They're frequent, and yet they're variable. We can't predict who's going to become agitated. We can't predict who's going to get depressed. We can predict in a group a certain amount of agitation might occur, a certain amount of depression, but we can't tell you for sure whether the person you care about is going to have these behavioral problems. And yet, we know that behavioral problems are closely tied to cognitive impairment. If you look at the screen, now this is the trick, they told us we have to say your side. So along your left, you will see mild, moderate, and severe. Along the right, the number of behavioral problems. The key cells here are mild impairment. 72% have 2 or fewer problems. Mild impairment, fewer problems. Severe impairment, look at the bottom right, 88%. So not only is the level of cognitive impairment increasing, but the level of behavioral problems are increasing. This slide just shows you the tremendous variability. These are all people with Alzheimer's disease who we have followed for a number of years. But the lines of deterioration vary. They all deteriorate, but they deteriorate at different rates. So we've developed our protocols to see if we can affect the rates of deterioration, if we can improve the types of behavioral problems they're experiencing, and if we can help the caregivers. Psychosocial interventions have a need that pharmacology interventions don't, and that is we have to really understand the interplay between the person, the caregiver, and the care recipient. Social learning and person-environment fit are psychological theories that help us understand. And simply put, it means you respond to what I do. I respond to what you do. Dr. Raskind tells a joke, you laugh. If you didn't laugh, he wouldn't tell jokes anymore. And I can tell you, having known him for many years, he tells lots of jokes. Clinically developed and applied. We've spent a fair amount of our professional careers working with patients with Alzheimer's and their family members. So we're not just sitting in a little room, coming up with what we think works, and writing about it. We're actually doing the best we can and learning, as you heard from Rebecca, from the families and the people with Alzheimer's disease who are willing to talk to us and help share their journey with us. And then finally, empirically evaluated. Because, as you heard from Dr. Raskin also, placebo is an amazingly effective drug. And the same is true in psychosocial interventions. If I'm a really nice person, I might be able to help for a little while. I probably won't be able to help in the long run, because in the long run you need skills and you need strategies. But randomized controlled trials are the way to evaluate. Are the interventions we're talking about better than just the test of time? Are they better than nothing? Are they better than some of the pharmacotherapies? So you'll be hearing data from randomized controlled trials that we do in my lab. So what are the key parts? First, it's a partnership. You can't treat patients with dementia and help their caregivers unless their caregivers and the people with dementia are willing to work with you. So it's a very close partnership that we develop over time. They're standardized and individualized. Standard because multiple people need to provide these interventions, and yet they need to be targeted to the individual caregivers and the patients. And as I mentioned earlier, skill building. I really believe that much of the interventions we have that work teach caregivers to become their own interventionists. And that's the trick, because we can't go home with you. So we have to give you the skills so you can take them home yourself. And the skills are straightforward. They may not be easy, but they're straightforward. The first is communication, and I will talk a bit more about each of these. How do you communicate with somebody who's cognitively impaired? How do you communicate with somebody who doesn't understand words anymore? Pleasant events. How do you make life more pleasant? How do you focus on things that people enjoyed when they no longer can do the things they used to enjoy? How do we figure out what people like when they can't tell us? Problem-solving difficult situations, because caregiving can be quite difficult, and sometimes the interaction between the caregiver and the care recipient becomes a struggle. And we want to help you get over that struggle. Behavior change, we have some strategies that I will talk with you about, and maximizing function. Because there are ways to make the environment more friendly. There are ways to make things easier so that even people with cognitive impairment can feel a little bit more in control themselves. And then finally, sustainability. Because as I just mentioned, it doesn't do you any good or us any good if the only things that work in a clinic setting. They have to work in your own home. They have to work when you're by yourself, when you're trying to provide care. So we've developed manuals, we've developed videos, DVDs. We've tried to export this and make it as accessible and available as possible. So let's talk a little bit about what kinds of skills. I tried to fit as many C's as possible into this sentence. I think I did well. Clear, compassionate communication is the cornerstone to care. I used to think that we could train people to be nice people. I really did. I thought there were structures and function and we could do it. And I've now decided if you're a nice person, I can teach you to be a good clinician. But I don't know how to teach you to be a nice person. So if you can bring that humanity to caring for people with Alzheimer's disease, we can teach you skills. But it has to be compassionate, and you have to really want it to be as clear as possible. We communicate at all sorts of levels. We communicate verbally and non-verbally. Think about when you're with somebody and one-on-one. They look at you, they might touch you, they smile, they move their hands. All those movements can be used to your benefit in communicating with somebody with Alzheimer's disease. And of course, verbal. When the world becomes a scary place, this more simple communication makes it a little more friendly. So one by one, simple commands, simple steps, giving people time. These are all things we work very hard at helping caregivers understand how to do. Two people sitting on a couch, she says, just having your arms around me is still the best medicine of all. And he says, and no side effects. I love doing studies that compare non-pharmacological to pharmacological because you know where the side effects are going to show up. Pleasant events. This sounds so silly, doesn't it? Pleasant events. But think about it. Think about if you live day to day and there is nothing in your day that brings you joy. How could you not be depressed? The world becomes scary. The world becomes unintelligible. So we want to introduce pleasant events for people with Alzheimer's and for the caregivers. So this is kind of stating the obvious, but sometimes when you're a researcher, you have to state the obvious. A pleasant event is anything that can add pleasure to a person's day. I'm not talking about a trip to the Bahamas, that would be nice, but I'm talking about basic little things. Like for me right now, not having that really bright light would make things much more pleasant for me. Every interaction has the potential to be a pleasant event. You're going to work with people anyway. You're going to interact with caregivers and patients anyway. You might as well make it pleasant. A colleague of mine had a sign in his office, and it said, all bring joy to this office. Some by coming in, others by going out. And pleasant events should be simple, accessible, and easily available. Big things, of course, can be pleasant, but what we need are lots and lots and lots of little things day in and day out. Sometimes pleasant events can be simple. Little guy sitting in his rocker, looking for someone to sing Row, Row, Row Your Boat with. And I don't mean to make it sound too easy. It's not. It's a difficult disease, and caregiving can be very difficult. So part of what we also talk about is problem solving and understanding that demented-related behaviors requires very careful observation. We've developed a strategy we call ABCs that has now been adopted by a number of people, including the Alzheimer's Association. So we're very honored by that. And we talk about A, B, and C. B is the behavior, A is an activator, and C is the consequence. And if you can understand the chain, you can start making changes. And problems, of course, interfere with your ability to care for someone. You heard Dr. Raskind talk about necessary care. And problem behaviors are when necessary care becomes difficult. And you can change a problem behavior. You can change it by preventing it or stopping it once it occurs. And understanding the mechanism of how behaviors happen help you get there. So here's our little ABCs. And you can see A leads to B leads to C, and C leads back to B. So if you change either what activated it or what the reaction was, the consequence, you can change what the problem is. It sounds simpler than it really is, but you can do it. In every interaction with two people, if one person makes the commitment to change, you can change the interaction. And if you're working with somebody who has a dementing illness, while it might not be fair, the person who's going to have to change is the person without the dementing illness. So one of our early studies was depression and dementia. We wanted to see whether we could alleviate depression in people who had dementia by working with their caregivers. I'm not going to go through the details of the studies, but I want to tell you what the results were. There were 2 behavioral interventions we tried which use the strategies I just told you about: communication, pleasant events, problem solving, ABCs. What we found here, what you see is the 2 squares that are below the horizontal line. In people with depression and dementia, statistically significant improvements in their depression by behavioral intervention. Much more than the minimally better, unchanged that you were hearing about earlier. Flat line for people who received no behavioral intervention or who received what was usual community standard at the time. So what this told us is depression in people with dementia will not go away by itself. It needs behavioral strategies and skill building. The other thing we found is that the caregivers themselves got better. These are 2 measures of the caregiver's own level of depression. Again, you see the same pattern. The 2 squares, the orange and the yellow, below the horizontal indicate statistically and clinically significant improvements in the caregiver's own rate of depression, and no change in those who received the usual community care or a wait list. So this says that by helping the person with dementia, you're helping the caregiver as well, and vice versa. This shows that over time, over 6 months, the improvements maintained in 69% of our sample. What that tells me is that they learned the skills we had hoped, and they continued to use the skills long after we were out of the picture. We then also looked at agitation. Multi-site study across the US. Some of the sites provided behavioral intervention, as I just described to you. Some of the sites, well, all the sites provided behavioral intervention, and we compared it to Haldol, one of the medications you heard earlier, and Trazodone, which is a less sedating antidepressant. What you see here, and I apologize that the blues and the whites kind of look the same, but what you see in the first little darker blue is our behavioral strategies showed improvement as much or as little, depending on your perception, as Haldol, Trazodone, and placebo. No change, the 4 boxes look about the same, and worse, the 4 boxes look about the same. So that tells us that no one medication was better than the other, and behavioral intervention really was not much better than the drugs at the time. There's a little bit of blip on one of the blue lines you'll see in that first improvement, but it was not statistically significant. So that's part of what led us to realize that we needed better strategies for agitation. But for depression, the behavioral strategies worked fine. We then took the depression strategies, the behavioral strategies that worked, and we looked to see whether we could enhance people who had physical problems as well as behavioral problems. People with Alzheimer's disease are often at risk for falls and fractures. And when they do fall or end up in a hospital, they don't respond as well to treatment because of the cognitive impairment and because of the confusion, as well as because of a variety of other factors. So we wanted to see whether we could decrease the physical disability as well as the behavioral disability. As I mentioned, people with Alzheimer's disease, they have more problems with falls and fractures. They're less likely to recover. And they actually, in many studies, have been found to be more undernourished because they're not eating right. and have more problems with just getting around, ambulation and mobility. So this was our exercise study. The first thing we wanted to see is, could we teach caregivers to engage in an exercise program with people with dementia? Or would it create more stress? We didn't want to do that. We wanted to make sure it was a pleasant event. We wanted to make sure they used communication strategies. We wanted to make sure they could do it. And the first slide shows you they could, in fact, do it. 3 months, the blue is our RDAD, Reducing Disabilities in Alzheimer's Disease study. You see it's much higher than the white, which was routine medical care, what these patients got by going to their physician and seeking whatever care they normally would have. At 12 months, the gains are not as dramatic, but the RDAD group is still ahead. And at 24 months, both groups deteriorate. So what that tells us is, yes, they could do the exercise, they could learn the program, but they need booster sessions over time to maintain it. These improvements in exercise correspond to improvements in depression. The rates of depression in people with Alzheimer's disease also improved, both at 3 months and indeed also at 12 months. And the real goal to this study, the thing we did not expect, and you'll hear this from most researchers, there are always surprises. That's part of why we keep doing it. Rates of institutionalization were not different between RDAD and routine care, but the reasons for institutionalization were dramatically different. People who had received the RDAD, the caregivers who had learned the skills training, were less likely to have to institutionalize the people they cared for because of behavioral problems. They were more able to deal with those problems and not institutionalize people because of them. So we've taken those strategies, we've looked at RDAD, as I've just mentioned. We've expanded to 2 other programs that we're very excited about. One we've called SPA, Seattle Physical Activity Program, and one we've called Rally. Both of those are exercise programs with behavioral components. SPA, as you can see, is for older adults. It's conducted in a group format, and it's self-directed, because these older adults are not cognitively impaired. And Rally is for people that have mild cognitive impairment. It's done also in a group format. It's self-directed, but with assistance, because they need help to remember the activities and the procedures. The last program I want to talk about is one that's probably nearest and dearest to my heart, and it's a dementia-specific training program that we developed for staff in assisted living residences. For those of you that may not know this, assisted living residences are the fastest growing residential care option for older adults. And it amazed me when I began looking at this how little training staff in assisted living received to care for people who were demented. And the rates of dementia and the levels of cognitive impairment in assisted living look about the same as they do in nursing homes. So very impaired people are living in these facilities with very little staff who understand what to do. So we set about to change that in a small way. We wanted to reinforce values of dignity and respect. We always want the staff to remember that these are people who have a brain disease, and they need to be treated with respect and dignity. We wanted to provide basic information on dementia and how it affects their life. There's my C's again. We wanted to train them in compassionate and clear communication. We wanted to teach them, just like we taught family caregivers, how to treat common care problems. And we focused on depression and anxiety because we had good results with that. And we wanted to teach them pleasant events. Now, pleasant events in a facility was interesting because we actually had some of the staff say to us, "That's not my job." So we actually made signs that we put around and posters that said, "Pleasant events are everybody's job." So here are the results. After 2 months, it was a 2-month intervention, but it was only 2 workshops. 1 workshop 1 month, 1 workshop the other, and then some hands-on supervision. The staff that received STAR and the residents in the facilities that received STAR showed improvements on the neuropsychiatric inventory, which you heard about earlier, is a behavioral checklist, if you will, that shows rates of impairment. The control group, the group that did not receive STAR, not only did they not get better, but they got worse over time. The same picture on depression. The residents in facilities that received STAR got better. The residents in facilities that received no additional training got worse. And the same picture on anxiety. So once again, we've shown that by teaching, in this case staff rather than family, skills, they can improve the care that's provided, they can decrease the behavioral problems, and that if you don't provide some kind of skill training, if you just do whatever normally is happening in many of these sites and in many of our communities, things get worse. They don't stay unchanged. Alzheimer's is a progressive disease. Things will get worse unless you intervene. We have done another study where we looked at training community consultants, people who were working in the community with older adults, and we taught them the skills that I've talked to you about, and then they went out to people's homes and worked with families. So what we're trying to do now is remove ourselves further and further from the clinical picture, because we need to get this intervention out into the community more. And we need a variety of professionals and non-professionals to do it. So what do we know now? We know that patient and caregiver depression can be significantly improved. We know physical activity can be increased and physical frailty decreased. We know institutionalization rates due to behavioral problems can be reduced. And we know we can improve care in assisted living residences. And we now are looking in adult family homes, and we're having similar good findings. But anyone who tells you any intervention works all the time for everyone is lying. This is not crisis management. These are not people who are in crisis, in a violent situation, in danger. These are people who are caregivers who are committed and willing to learn the strategies. It does take caregiver commitment, and I don't have a simple answer, but I know that we need to begin to develop strategies for people who don't have caregivers involved. It does require professional time, but as I mentioned, less and less as we continue to refine what we're doing. And it does, at this point, require specialized training, but also, as we continue to articulate and have it clearer in manuals and videos, it will require less and less specialized training. And we have not investigated in multi-site clinical trials, because if you think it's hard getting research going on without drug company money, try doing non-pharmacological trials. I'm going to almost end on this. Grandma's sitting in a chair, and she says, "Phew, that's a relief. I thought my eyes were going bad, but I was wrong. I didn't need eyeglasses. I just needed a bigger watch." Well, of course she needed eyeglasses, and of course her eyes are getting worse. But the quality of her life will improve with the bigger watch. And that's what we're working very hard at doing. Thank you.
Okay, now we'll ask Dr. Raskind and Dr. Teri to come take the hot seats in the middle of the room.
What is placebo anyway? So placebo is the old sugar pill. Or starch pill. It's something which looks like the active medication, but doesn't have any known chemical properties on the body. Yet we also know that taking a placebo and the active being in the study and expectations all combine to themselves produce an effect. And what we're hoping is that the effect of our active medication is larger than the placebo effect. Sometimes, if the medication does the wrong thing, your placebo can be better than the active medication.
Thank you.
Thanks for asking.
an incident that happened last fall. My father-in-law, who has Alzheimer's, is in an assisted living, and he fainted or something. They thought he might have had a mini stroke, so they brought him in and did, I guess, was it MRIs or scans, in any case, brain scans, to see this situation. And the doctor who was looking at him was quite shocked to find out the next day that the amount of kind of holes and the amount of cerebral fluid in his brain, because he had been up joking with him. So linguistically, he still jokes and kind of seems quite sharp. He didn't think that he showed the types of symptoms that he would have thought of were as typical of Alzheimer's, although in many other respects, of course, he totally is typical of Alzheimer's. But this particular aspect of being able to make jokes and things of that sort, do you have any thoughts on that?
Okay, I'll start. Let me make one comment, and then I'll try to answer what's a difficult question. But I left one slide out in the interest of time. And that slide had on it, the first thing you try are the behavioral interventions that Dr. Teri talked about. Because if those work, they don't have adverse biological effects. They can be highly effective, and you don't need to go to a medication. That's one. And the second comment related to that is that sometimes for the very difficult patients, it's a combination of behavioral interventions when training and all the things Dr. Teri talked about, together perhaps with a medication that could lower the temperature of the whole situation, so that the best treatments are often combined. Now, to try to answer your question, and this is a memory test for me. So, if the brain X-ray, if you will, shows a lot of damage, but the person who happens to be the holder of that brain, which was just X-rayed, is verbally still able to communicate to some degree and even joke and, quote unquote, kid around or be able to remember songs. Lots of things. There are lots of things that are often retained, provided that you don't put pressure on the system and ask that person to perform in areas that, in fact, are damaged by the changes being seen on the X-ray, such as complicated tasks or recent memory for multiple events.
There's another part and that I think makes Alzheimer's disease particularly frustrating from the person's perspective and the caregiver's perspective is overlearned strategies, skills that we've used for many, many years are often the last skills that we lose. So, as you can probably tell, we joke. We will probably joke when we are significantly demented. Now, we probably will make just a little less sense than we make now, but...
We're hoping people will still laugh just to keep us calm.
So I expect with your dad, what's happened is that's who he is. And so he's able to continue that, and he's able to socialize. Now, his brain is significantly impaired, but that's overlearned, old neurons, it's really in there. And that's probably part of what's happening. Does that make sense?
Yeah, good point.
Actually, it totally makes sense. And I just wanted to add to that that because he was involved in work such as running restaurants where he was constantly joking with people over his lifetime, and probably his biggest disappointment when he retired was that he didn't have that type of ongoing stimulation. Many of us felt in the family that things actually seemed to improve for him in a lot of ways when he was in an environment now in an assisted living center that's large enough that there's a lot of people and staff to interact with him in positive ways. And it wasn't just about getting things done the way it was with us in the family. My daughter, who was away at college, when she came back 6 months later, said, gosh, he just seems better, in a better mood and more sociable and so on. Thank you.
I'd actually like to comment on that because that's a wonderful comment. You know, loneliness is really a hard disease, and we don't talk about it a lot, but it is critical, and lack of social interaction, I think, is terribly debilitating, and that's something else we don't talk about. And so I really commend you for realizing that. And then I think, especially in this forum, we need to say that. You know, we are social animals. We need interaction. We need verbal communication. We need physical touch. And unfortunately, our society is such that as we age, we lose a lot. So I think that's also part of what we're seeing in many cases. So I commend you for realizing that.
I don't know if any research has been done on it. Maybe it has been done. Genetics, like mother and father, at the time of their demise in late, say like 90s, one parent is great. The other one lost little, memory. Will this affect children? Okay, will mother's genes go to daughters and fathers to sons? Has anybody done that, or?
Well, the question. So to answer your question, it's the multiple questions. I, being the son, get half the genes from my mother and half the genes from my father. And everybody in this room who is either a daughter or a son, which includes at least the majority of people here, has that same situation. Secondly, a broader question is, and it's a complicated question, we don't have time to go into detail. If you have a parent who develops Alzheimer's disease, does that increase your risk? Was that passed on, whether it was your mother or your father? And simply put, if they developed it very early, it somewhat increases your risk to the normal population. But if they developed it over the age of 75 or 80, it doesn't increase a meaningful risk of getting Alzheimer's disease. That's a very simple answer, and there are lots of variations. But so I would sleep calmly tonight.
Thank you very much.
Yeah.
With your talk about keeping human dignity and remembering that the person suffering dementia is still a person, where do you draw the line when that person doesn't want to, kind of wants to hole up and not socialize and not do the things? How do you draw the line between allowing them to make that choice versus helping them get better?
That's a really important question. And as a caregiver, whether you're family or staff, that's something that you have to struggle with. And it's good that you think about it. You know, I think where we get into trouble is when we forget that the person with dementia still has rights. And they still can make decisions. They may not make decisions we necessarily like, but they can still make decisions. So I think just raising the question, good for you. And in terms of where do you draw the line, I think there are probably many, many factors, but simply necessity. That's where you draw the line. Safety, necessity. You know, for example, I've worked with families where there's a struggle because daughter wants mom to take a shower every day, and mom won't do it. And does she need a shower every day? I mean, that may be, you know, somewhere along the line we all learned we were supposed to take a shower every day, but do you really need a shower every day? That kind of thing. And to get to the point where you realize, no, and she's not going to get sick if she doesn't take a shower, and she's not going to be in danger if she doesn't take a shower. So that's necessity and vulnerability or danger is where I would think about it.
Because I think one of the things that Dr. Teri and Dr. Logsdon have actually taught me that I use a lot in my practice is that simple but so important concept of increasing pleasant events. And you can often think about how can I increase pleasant events for this individual in a non-authoritarian way. And it takes some creativity, obviously. And a part of that is that, you know, we're all have different things that are pleasant to us. Like, you know, just talking about earlier in the questions, someone who was a restaurateur and thrived from multiple social interactions every night, being in a busy social interactive environment is extremely pleasant for them. and will have mood elevating effects, likely. On the other hand, the other extreme, there are some people who have always been content and happiest when they've been by themselves or in an environment with low stimulation. And we have to know a person's lifelong history of what was positively reinforcing or pleasant to them so that we can decide how to increase pleasant events for that individual.
Thank you very much.
And with that, I also want to thank Doctors Raskind and Teri for spending their evening with us and sharing this information.
Thank you.